prepare the patient suffer with achalasia, and the operator is Professor Linghu.
有一個 poem 嘅 case， 好。
Professor Linghu, you know, now is the president of the Chinese Society of Pediatric Endoscopy.
Yes.
Then first we will introduce the case. Now give the case report.
Okay. This patient is female, 58 years old, dysfunctional and chest pain for more than 2 years. The diagnosis is achalasia, suggested by narrowing with the classic bird speech appearance of the distal esophagus. Esophageal manometry showing epistaxis, lower esophageal sphincter pressure is 14.8 mm mercury, confirms the diagnosis. A fine ring-like structure can be seen at lower section of the esophagus. The diagnosis is achalasia. Welcome our demonstrator, Professor Linghu.
Yeah. Now, first of all, we enter an endoscopy to the G junction. Like look at here, and this case is it's slight loose. That's a cause we prevent.
Can we have the endoscopy view, please?
We look at the esophageal cavity that is not tutor, and we classify that is limb 2A. Then we enter the endoscopy to the G junction. Look at here, and this is for several times pass through. And before perform the operation, and you know that is the first stage we clean the esophagus, so this is easy to pass. Now that's the end of the endoscopy point. That is about 38. So we turn back about 10 centimeter longer. Yeah, and from here we'll injection, and for the tutor, the tunnel technical interest. Now injection. That is the methylene blue. As here, okay. It's a 7 millimeter. Okay. Now we use the triangle knife.
Professor Linghu, you always use a posterior approach?
What? Pardon?
一般你是在6点钟开始的，对吗？是前面的啊。
Yes. Okay. That is the T shape. Invert. T shape.
Broken.
这个气给的不太好。
Professor Linghu is making a T incision, I think.
Yes. 这气不好，所以是这边这个视网腔就起不来。你看看这个气不行。
试一下气水。
气水撒点。
好。
Now that is converted T. It's easy to interest. It's no problem.
No education.
That's the head. From two sides to the middle.
Very clean. No bleeding.
令狐教授，这个 tunnel 的长度是多少？
啊？
这个隧道的长度是多少
10公分左右。
10 to 8 and 10 to 11 centimeter.
？10 centimeters.
From side to the center, we can keep the width of the tunnel. Here is injection.
Now injection again.
Vertically. We have go ahead about 5 centimeters.
Okay.
就the submucosa tunnel.
Yeah. Each time injection, that's about 3 millimeters.
And about 2 to 3 centimeters into the proximal stomach.
Professor Linghu proposed a classification of achalasia in 2013. He described achalasia into 3 types, and this is a type 2 with the presence of multi-ring or crescent-like structure. I think the type 3 are the ones with the diverticuli, and the type 1s on the endoscopic images you do not see the rings, so it's only manometric evidence of achalasia. So Professor Linghu, when he went into the esophagus, you could see multiple crescentic structures as he entered the esophagus. So I guess this is how I interpret
It's
it.
very clean.
Yeah.
介绍隧道。这说是另二型。
Type 1.
他介绍一下令分型。
你给我介绍一下，你把那个。
Based on the link classification, the esophagus of type 1 is very smooth and without multi-ring structure. crescent-like structure or divicular structure. So the type 1 patient are the most safe type and it's easy to undergo POM. But for the like this patient, this type 2, Ling type 2, it's this patient, the esophagus with multi-ring structure was not so smooth as type 1, but not much difficult. This type is easy during established submucosal tumor in our practice of POM. So both the Ling 1 and the Ling type 2, Ling type A is absolute indication for POM, like this patient. Here we hear the G junction. The type 2B， 你刚才说这个是 2A 是吧？哈。
对对。
Type 2B or 2C is actually reflects the tautness of the esophageal lumen. And the degree of the tautness is more severe in Ling 2C than in 2B. And therefore, so it's established submucosal tumor across the tautness point of the esophagus is more difficult and more likely to cause proliferation in Ling 2C than in 2B. So these two types is also difficult to establish the submucosal tumor. So the divicular structure occurred in type 3, making it the most challenging type to establish a submucosal tumor across the divicular. So we the standard tumor POM will be built is about 2 to 12 centimeter tumor. The indication is applicable for type Ling 1, Ling 2, and Ling 2B. So the short tumor POM will build 6 to 8 centimeter long. Indication is applicable for types Ling 2C and Ling 3.
So I suppose the type 3s are the difficult ones to treat because of the associated diverticulum.
So I think that's the end of the tunnel. So let me look at from the esophagus. Look at here. Let's come here. Okay. So
often pass of the G junction is about 2 to 3 kilometers into a proximal stomach.
So now we perform the mask incision. Okay. And from here.
We start meiotomy.
So you perform a full thickness cut?
So we are looking at the circular fibers, right? So a full cut would be the circular and then the vertical fiber.
你会做的这个全切吗？
会的。We call it a granular insection. First of all, it's ring muscle.
Incision to extend to 3 centimeters into the
Yes,
stomach.
look at it here.
You can see the vertical fibers now.
Yes. Right.
I suppose the next structure would be the pericardium.
Yeah. From here, and completed.
完全这个，
Without the hemostasis,
完全这
no
个，
bleeding.
这个是整个全身血管。
冲下去，冲下去。这可能有点。
Myectomy started 2 centimeter distal to the incision. 2 centimeter.
Late.
这个全血管。全程切开是那个
Clean.
就是
I've
是
seen
这个
different
切开。
techniques, some pull back and some pushing forward. So I guess as long as the cut is okay.
Yeah.
止血钳。
Use coagulator.
How can you tell you are inside the stomach? Are we in the stomach yet? 我
Yeah.
们在胃哪边？我们切到胃哪边没有？
这是指害了术后的吗？啊，胆囊切除术后，我看到有个伤疤。
放点。张开。这样。放点。OK。
但是还得往。
冲下水，我看看。这样，好。这个可能有点寸。张开。抱着。好的。放。
有点。
到切个到。
You didn't cut a lot of gastric muscle, right? 你没有切到这个胃哪边的肌肉没有切到太多，对吧？
打开了胃的肌肉。
就靠那个，再往下一点，再突出一点。
出来。
有点粘。
没事，不要紧。
你小心上面黏膜。
知道。OK。
往那边来。小心。
OK。That's enough.
Professor Linghu is very famous endoscopist in China and in the world, particularly for poem.
OK, almost. That's enough. OK, we were finished.
Professor Linghu, how do you know you've cut enough on the gastric side? 我的意思是你如何去决定你gastric side 那个已经完全切开？
I think that's enough.
Oh, it's
So
enough.
you can look here. That's maybe a little bubble. It's from the 小网膜囊
Okay,
机器。
I suppose you can see it from the inside when you retroflex the scope.
Great successful.
And this is from the esophageal cavity. Look at here. It passes through easy. And look at the G junction.
I see.
It's large.
Okay.
Yes.
So you are not feeling the
So,
resistance. So your scope can pass easily. Okay.
Yes. So now we will close.
The melatomy often studied at 2 centimeter distal to the incision and extend 2 to 3 centimeter into the stomach.
Okay. Open. We use this is micro teach.
Okay, microtech clips.
Yes.
So I can see the advantage of making a T incision because it appears that the T is a little easier to close.
Yeah.
Yeah, it's very easy to the T-shape incision. Very
I can
easy.
also see Professor Linghu closing a little bit of a normal mucosa just distal to the tip. So yeah.
It's just need 4 to 5 clip. It's enough. It's about 1 centimeter longer.
Okay.
Clips do you use?
4 to 5.
5.
Okay.
About 5.
1 to 5. So here is just a little. Okay.
后面再2步够了。
3.
Okay.
One by one.
So now your procedural time is around 30 minutes for each form?
No, much less. We're just, I think we are running ahead of time. Professor Linghu, what is your post-operative management regimen for the patient?
Yes, the patient will stay in hospitalization about 5 to 7 days, and about the first 3 days is 禁食的，so 禁食72小时。Fasting 72 hours.
So the patient's kept fasted for 72 hours. I presume the patient goes on a little bit of PPI. Do you do a swallow at the end of 3 days to check if there's a leak?
Liquid.
So you don't routinely do it. Anthony, what's the regimen in Hong Kong?
We only did it when we first started, maybe 10 years ago, but nowadays we don't really.
So they go home on the same day and they start eating.
They start eating the next day.
Okay. But how do you check the mucosal integrity?
I think the most important is to make sure you close it properly during the initial endoscopy. We used to check it, but after about 50 cases, we found that it's probably not really. Chances of being
One more.
very low.
So how do you know if there's been a complication?
Well, the patient will come back with fever, and then on chest X-ray, there might be some pleural effusion.
But then that's a leak, a mucosal leak?
Yeah.
Okay.
The last one is finished.
Okay. Okay, it's finished.
Finish it.
很精彩。
谢谢。
Excellent.